in the trenches, number whatever. Okay, this morning I'm going to discuss acid base, few words on acid base. First thing, distinguishing between an acidosis and an acidemia or an alkalosis and an alkalemia. Acidosis is a process that produces acid. Alkalosis is a process that produces bicarb. Acidemia means your pH is under 7.35. Alkalemia means your pH is greater than 7.45. The lower or higher the pH is, the worse problems you have. So when you have a problem regarding acid base in a patient, you kind of need to sort out what it is. So let's start out with patient has an acidosis or an acidemia. pH is under 7.35. The first question is it metabolic or respiratory? If it's metabolic, okay, then the next question, you need to determine if there's an anion gap. If you have an anion gap, then you have an anion gap metabolic acidosis. And if not, you're what's known as an AGMA or non-anion gap metabolic acidosis. This, we think of the different mnemonics for this, get into that in a little while. Okay, the next thing is there a secondary metabolic problem? So a patient could have an AGMA plus an AGMA, or they could have an anion gap metabolic acidosis plus a metabolic alkalosis. Some people with diabetic ketoacidosis vomit so much that they become alkalemic, and that's called diabetic ketoalkalosis. Okay, and with this you use a formula delta 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 bicarb. If somebody is a pure increased anion gap metabolic acidosis, then the delta delta, the number of unmeasured anions, will be the same as the loss in bicarb. However, if the delta delta is greater than the delta bicarb, it means they're generating some bicarb back, and they also have a metabolic alkalosis. Likewise, if it's less than the bicarb, it means that there are two metabolic processes going on. Okay, if somebody is a metabolic anion gap acidosis, you're going to think of, there are different mnemonics. The most common mnemonic used now is Goldmark. Before it was Kussmaul, but the glycoaldehydes, ethylene glycol, propylene glycol, oxyprolines, L-lactic acidosis, D-lactic acidosis, methanol. These are the ketoacidosis. This is renal failure. And the A here is aspirin. But when you're going through this, you're going to think of lactic acidosis, the ketoacidosis, uremia, renal things, and then the toxins, usually the toxic alcohols, methanol, ethylene glycol, aspirin, although these aren't as common. When you're thinking of a non-iron gap metabolic acidosis, okay, this is where urine electrolytes are important. Normal urine anion gap should be negative. And if it's positive, you're with anagma, you can't put bicarb in the urine. And also, often you see this due to hypored and hypoaldo states like type 4 renal tubular acidosis, aldo resistance, primary adrenal insufficiency. So urine sodium plus potassium minus chloride, this should be negative. If it's not, and if it's negative and they have anagma, you think of GI losses. Most common being diarrhea. You can also see it with fistulas. You look at a book, you can see it with a lot of other things. And if the urinary gap is positive, you think of type 4 RTA, adrenal insufficiency, renal insufficiency. Here you can also see it with carbonic anhydrase inhibitors like Diamox. Sometimes you can see it with Topamax. Then after that, after you declare another metabolic problem, you're going to find out if there's a concomitant respiratory problem. And here you're going to use Witter's formula. And that the PCO2 will equal the bicarb plus 8 plus or minus 2. You just plug that in, that's total versus your medical score. If you look at the Henderson-Hasselbalch equation, the body wants to maintain as normal pH as possible. So if your bicarb drops, your PCO2 is going to drop. You're going to hyperventilate. Likewise, if you generate bicarb, your PCO2 is going to go up. For metabolic alkalosis, it's a little trickier. Most common causes are severe vomiting or severe ingestion or diuretics, especially overdiuresis with low diuretic. And without going through, normally it's a contraction alkalosis. But as far as finding out if there's another metabolic problem, there's not, Witter's formula, there's really not a Witter's formula for metabolic alkalosis. What's used now, depending on the severity, if you have a mild metabolic alkalosis, then you could say the PCO2 equals the bicarb plus 15 to correct it. And if it's severe, greater than 35, the bicarb plus 10. For the primary respiratory problems, you're going to see certain corrections. Respiratory alkalosis, there are a lot of things that can do that. Sepsis, liver disease, aspirin toxicity, severe anxiety. But if your PCO2 goes down 10, your bicarb acutely will go down 1.5 to 2, and chronically 5. Okay, likewise, if you have a respiratory acidosis due to hypoventilating, severe COPD, severe respiratory failure, neurologic disease, neuromuscular disease. If your PCO2 goes up 10, acutely the bicarb will go up 1, and chronically over 48 hours will go up 3.5. So the approach to acid-base disorder, you need to find out what the primary problem is. And then you need to find out concomitant causes of the primary problem or the secondary problems. And then you treat them, but you don't need to know what's causing them first. And with this, I'm going to stop.